Good morning. Uh, my name is Anita Day. My pronouns are she, her, and I'm chair of Eastern North Herts Teaching NHS Trust. Welcome to this morning's meeting of the Trust Board in public on today, 19th of November 2025. As usual, my welcome to members of the board, any attendees that we have today, and indeed anyone joining us on via YouTube, either live or looking at the recording. We've got a full agenda today, so I think we'll crack on. So first of all, declarations of interest. Everyone will have seen the agenda on the on the website. Does anyone have any declarations specific to this morning's agenda? Nope, thank you very much. Apologies for absence. I have received apologies from three non-executive directors, Richard Oostrom, Nina Janda, and Teacher Farah Firi. I'm not aware of any other apologies. I think that's right, Stuart. We've not had any others, have we? In which case, let me move on then to the staff story. We have a lovely story today, and I'm going to hand over to Penny to tell us about it. Thanks, Penny.
Thank you very much, Chair. So good morning, everyone. So I'm very honoured to welcome Tony Malbus to the meeting. Tony is one of our nurses at the Trust. Tony and I met a couple of months ago when I took over as executive sponsor for the Race Equity and Cultural Heritage Network. And Tony came along to share her story with us. And on hearing it, I thought immediately, we need to share this more broadly, both with the board and with if you're watching on YouTube or streaming this afterwards. It's a really inspirational story. And it showcases the inspiring journey of an internationally educated nurse who arrived in the UK from the Philippines. And if that wasn't a big enough change, she decided to do that during the height of the COVID-19 pandemic and join the NHS. And I think this story really does highlight courage. It's a story of courage, story of resilience, dedication, and how Tony transitioned from a pre-registration nurse to becoming a practice development nurse in our emergency department, which is where she is now. And it's really a journey of ebbing and flowing, as you'll hear in a moment from Tony, and starts really when she failed her clinical exams initially to where she is now, which is training and supporting over 200 internationally educated nurses. And it really does demonstrate how personal perseverance, coupled with the support that the Trust has given her, can really change lives, both her life and the trajectory of her life and those that she supports, but also for our patients and anyone who uses our services. I think it's fair to say we have an amazing team of dedicated individuals who provide care day in and day out, many of them from diverse backgrounds who have overcome their own challenges to be with us in the Trust. So it's a real celebration of diversity as well as personal resilience. And I think it can show what an individual can achieve when they have the right support. And I think the final thing I'll say before I introduce Tony is, when I heard the story and when others on the network heard the story, it brings up a range of emotions because it is such an inspiring journey. And I think I would say to anyone who is watching this now, who is challenged or struggling, listen to this story and take heart, because it really is a journey of overcoming obstacles. Your time, Tony, and please, whenever you're ready. Thank you.
Good morning, everyone. My name is Tony Malbas, but my full name is Maria Antoinette Malbas, but I would prefer my colleagues and workmates to call me Tony. So let me share you my story of resilience, growth, and continuous pursuit for better things. Okay. Um, when I arrived in England from the Philippines amid the COVID-19 pandemic in February of 2021, I carried with me a mix of excitement and uncertainty. I didn't know exactly what awaited me in this new country, but I was ready to face it. Although this wasn't my first time working abroad, having served as a critical care nurse in Saudi Arabia for over 2 years, I started out again as a pre-registration nurse in the emergency department in the UK, presented a new and unique set of challenges. I knew the path ahead would test my strength, my resilience, and adaptability in ways I couldn't yet imagine. By May 2021, I faced my first big hurdle, the OSCE assessment. Failing my first attempt was a heavy blow, but it did not break me. Instead, it fueled me to push harder, study smarter, and rise again. In June 2021, I passed on my second attempt. That moment was more than just a success. It was proof that setbacks are stepping stones to growth and development. With my NMC pin in hand by July 2021, I stepped into a role of a Band 5 staff nurse in ED, where the real test of resilience began. The environment was demanding, short staffing, relentless pressure, and the weight of caring for some of the most challenging patients and cases. But each shift honed my skills, sharpened my judgment, and deepened my compassion. In March 2022, I dared to aim higher. I applied for a Band 6 role as a practice educator for international nurse training and OSCE support, and by June 2022, I had started that role, guiding and empowering more than 200 internationally educated nurses through their OSCE journey, many of whom had walked the same difficult path I once did. Helping them succeed became one of my proudest achievements, turning my own struggle into a source of strength for others. In November 2023, I was honored to attend the King's reception at the Buckingham Palace, hosted by His Majesty King Charles III, to celebrate international nurses and midwives, sharing with us his 75th birthday. Standing among colleagues from around the world, I felt proud of the journey I had traveled. From failing my OSCE to being recognized on such a prestigious platform. By December 2023, another door opened, a secondment as ED practice development nurse. It was a role that demanded not only my clinical expertise, but also leadership, mentorship, and vision. The work stretched me, but it also showed me how much I had grown over the years. In March 2025, I was made permanent in the role, and it's a milestone that affirmed my resilience and dedication. Early this year, I was humbled to receive multiple DAISY Award nominations from patients, relatives, and colleagues who recognized the compassionate care I provided, as well as the tailored guidance I offered to colleagues to help them grow and thrive in their clinical practice. This included dedicating my own time, working additional weekends and nights outside of my usual Monday to Friday schedule. This is to provide focus, support, and mentorship. Although I was not selected as a DAISY Award recipient, being nominated was incredibly meaningful. It reminded me that the time, care, and encouragement we invest in others truly help them thrive. I felt deeply recognized, valued, and empowered to continue supporting my colleagues and patients with care, empathy, and dedication. Just recently, I was named a finalist for the Nursing Times Award, Workforce Award in the Practice Educator of the Year category, with the award ceremony scheduled for next week. Being recognized at this level reinforced that perseverance, dedication, and the support I give to others that truly makes a difference. Looking back, my journey has been anything but easy. From failure to triumph, from frontline chaos to leading change, I have carried resilience as my anchor, with every challenge become an opportunity to grow and every setbacks a lesson that fueled my determination. Today, I take pride not only in the nurse I have become, but also in the nurses I have supported along the way. My story is not just about resilience, it's about transformation, leadership, and the power of rising again and again. So before I end my story, I'd like to share a Latin phrase that has guided me throughout my journey. Semper ad meliora, which means always toward better things. It is a motto of resilience and continuous improvement, suggesting that one should always strive for progress and growth, even through challenges. To me, this captures the essence of resilience, not just surviving through challenges, but growing, thriving, and continuously improving because of them. Life will always test us, that's for sure. But it is through those very tests that we discover our strengths and potentials. Thank you very much for the opportunity to share my story.
Tony, that was wonderful. Thank you so much for sharing it. And I think, as you know, as Penny was saying at the beginning, I think it is such a an inspirational thing. And as I say, and I think I have, my parents were immigrants to this country, and to come to a country and deal with the cultural stuff as well as dealing with your career, I think is a phenomenal thing. So this is really, really special. I'm going to throw it open for questions or comments from my colleagues. I did have one for you, if I might, just to start. Obviously, you had that initial knockback with your first OSCE, which you failed it. Looking back on it now, do you understand why you failed? And is that something that you've been able, given that you're now supporting international students through their OSCEs and things, is that something that really helps you to prepare them better?
I think that setback really honed me, as I've mentioned earlier. And being an OSCE trainer as well, I have realized why I have failed the first time. It's it's because of multiple factors. Being in a new country, adjusting to the new environment, new culture, the workload itself, the pressure, and the limited preparation time. Not to mention, it was at the height of the COVID-19 pandemic. So it's like multifactorial. But then I am always grateful that I've been in the best trust in the whole United Kingdom. And having said that, I know for sure that we are always providing the best support that we can have for our internationally educated nurses.
That's lovely. Thank you, Tony. Right, we've got some hands. Janet.
Thank you. Yeah, Tony, just to say that was just really, really powerful. And thank you so much for everything you're doing, particularly that support you're providing in ED. You're not just in the kind of 9 to 5, but across that whole sort of 24/7. And it sounds like you're really taking opportunity to embed your learning in the approach you have now, which is fantastic. So thank you.
Thank you.
Absolutely agreed, Janet. Karen.
Hi. I'd like to begin just by echoing what has already been said. It's a really inspirational talk that you've just given to us. I do have a question though, and that is, you've talked a lot about your own personal resilience, but is there more that we could do as a trust to help our people who come in from overseas, or indeed to help anybody who is going through exams, to help and to support them through this process?
So, personally speaking, the support I received from failing the OSCE exam up until I passed it the second take was actually excellent. And I know for a fact that this trust has been a supportive employer, especially for those internationally educated nurses. I know that we've been supporting our nurses all throughout their onboarding, from recruitment to onboarding, until that such time that they're settled into their new roles. So what I can actually say is that we should just be like empowering individuals to support, not just those that belong to the leadership and management, roles, but also those that are actually like our junior member of the staff. We need to also empower them to support each other, because I think whenever we support each other, whenever there's like a good support system, I think everyone would be resilient enough to perform their duties and to deliver the best and the quality care we should be providing to our service user.
Thank you. Teresa.
Just a quick thank you, Chair, for me, to the most amazing Tony, who role models clinical practice all the time in the ED, not just teaching in the classroom, working shoulder to shoulder with our nurses, our doctors, our CSWs and our housekeepers. And, you know, we get the most amazing feedback, Tony, about you and the team. So thank you.
Thank you.
That's lovely. Thank you. Kevin, I thought I saw your hand raised earlier. Have you changed your mind?
Karen just asked my question because I was interested in sort of the wider reflection you'd have, sort of, Tony, on how we can improve things for everyone moving forward. But I would just take the opportunity, because it's been such a powerful story, just to echo what everyone else has said. What a really inspiring journey that you've had. It's really unbelievable, and you're such a role model for so many other people, and that is really inspiring for our staff. Your resilience is amazing. The passion that I hear in your voice is something that's really special. For me, with my kind of perspective, you're just such a natural person that seems to sort of get rich insights and reflect, and you're always focusing on better is better, improvement, and that's just a lovely piece and something that we're really trying to foster across the organisation. So thank you for everything that you're doing there as well. And if I was on the panel next week, I know where my decision would be going, so I'll be rooting for you when you're up at the awards next week. Well done, and thank you.
Thank you.
Very, very well put, Kevin, and absolutely. So, yeah, I echo everything everyone said. Tony, thank you so much for taking the time to join us today. It's been really lovely to hear your story, and it's wonderful that you are getting recognition from these nominations for these awards. Let's hope it goes your way for next week as well. But actually, what you are doing day in, day out for our team is golden. It's absolutely brilliant. Please keep sharing your enthusiasm and your story. Please keep sharing your commitment. And your message about empowerment has not fallen on deaf ears. It's something we believe and are trying really hard to do, to make everyone, regardless of their role, believe that they can make a difference to patient care, patient safety, and so on. So please keep that enthusiasm and encourage your colleagues to get involved with projects and things that can really help our patients. But thank you again for your time today.
Oh, thank you, everyone, and I hope I have inspired you with my story. It was nice seeing everyone. Stay warm.
Thanks a lot. Bye. Right, so lovely story. Let's move on then to the minutes of the last meeting. Now, I was actually not here for that one, so Karen very kindly stepped in for me as chair for that board, and I think she's approved the meetings. Does anyone have any comments or clarifications or amendments to the meeting minutes as they are in the pack? No? Okay. We're happy to take those as approved. Thank you very much. Moving on then to the action log. We've got quite a few things that have been completed. Stuart, do you want to say anything about any of these items?
So the Renal Services Action Plan has been uploaded onto the web as promised. The action on the revised terms of reference for Digital Committee, that will be coming to January's board as set out. There's a couple of freedom to speak up actions, and on the second page of the action log, there's an action for January which is in hand, and there's also an update on the where we're aligning freedom to speak up with the EDI strategy. Penny was just going to provide a quick update in terms of the request from Freedom to Speak Up champions around protected time, if I could pass over to Penny.
Thanks, Stuart. The Freedom to Speak Up Guardian, Sylvia Gomez and myself met. She's done a business case, which I don't think is unreasonable, asking for a short period of time for the Guardians to have some protected time. It's essentially 1 hour a week, so 4 hours a month. I'm very supportive of it, and I'm now working with Sylvia to see how we can embed that in and join that up with other priorities that we have, particularly around psychological safety. So board members will be aware that the end of November sees our staff survey come to a close. We have a couple of months before we get the results, but it's something that we're working on in terms of improving the lives of all of our colleagues. The psychological safety is a really important one for us. So we'll be looking at how we can utilise that time to perhaps take forward some of the themes from the survey, but actually things that we know anecdotally as well. So I would say that's very much in hand. It's in progress, but it's moved on since we last spoke.
Thanks, Penny. Janet, you wanted to come in.
Just to add my support really to what Penny said, and I mean, reality is I think that they are people are using, you know, time. They're sort of trying to carve out their own time as best they can. So I think given the importance of the agenda, it's really positive that it's moving forward, because I know we discussed this action some time ago.
Diana?
Thank you, Chair. Just to echo again, thank you very much, Penny, for really focusing on this one. It has been around for quite some time. I just hope actually that when we do come to look at the alignment work with Freedom to Speak Up, that we make sure that we engage as many people as possible in that process, so we get to hear from everyone.
Yeah, thanks, Diana. Good points too. So thank you for that update. As regards to protected time, then the business case is in train at the moment. So you at some point you'll let us know what the outcome of that is. I mean, I think all of us on this board would recognise the value that has been brought to the role of Freedom to Speak Up, and the engagement with our people is I don't think that's in any doubt. Clearly in the financial circumstances that we're in, we recognise that sometimes makes these decisions a little tougher than we would want them to be. But that's no reflection at all on the job that Sylvia is doing and the impact it's having on our people. So let's see what is possible. Thank you. Has anyone else got any other comments on the action log? Are we happy to move on? Happy? Okay, brilliant. So let's move on. The next item is questions from the public. I believe there have been none received, Stuart. Is that correct?
That's correct, no questions.
Right, great. Okay, so let me come to my report, which is a verbal one. And I think that all I really want to say is I want to say thank you and pay tribute to everyone at this trust who I know is working flat out at the moment. This is an incredibly challenging time, and I'm talking about everyone from our executive team to divisional and care group leadership, right down to our patient-facing staff on the front line. Everyone is absolutely focused on looking after their patients, and doing so at a time where there are many challenges, and we're all aware of the sort of the financial landscape that we are operating in. Clearly, that level of stress and level of work is adversely impacted by things like the industrial action that we have just seen, the end of a 5-day action by the resident doctors. As a trust, we absolutely respect the right of staff to take action when they feel necessary, but we also absolutely recognise the impact that has on everybody else. And at a time when everyone is so stretched, we know that this has been a really difficult time. So on behalf of the board, I'd like to pay tribute to everyone who has stepped up, who has done things above and beyond, who has done slightly different roles or taken slightly different activities on in order to keep things going and to keep our patients safe and to keep our services on the road. So our thanks, on behalf of the board, I'd like to thank everyone who's been involved in that. The only other thing I wanted to say is since our last board, we were asked at relatively short notice to submit a capability self-assessment. I'll say that again, a capability self-assessment to NHS England. That there was a deadline in October. The team stepped up, put in a very thorough assessment, which it was at a time where we didn't have a board meeting, but we did have scrutiny by both the executive colleagues and non-executive colleagues. And I think we've had some positive feedback on that from NHS England, but it was submitted within the deadline. I think I'm going to leave it at that. Just one other thing. The charity accounts were also due, but what we will be doing is, I think there is a charity trust committee meeting, I think, coming up in early December. I think the accounts will be discussed there. And then what we're going to ask to do is to delegate approval of those accounts to the Audit and Risk Committee. Can I ask for approval from the board? Karen, you wanted to come in on that.
Yeah, it was simply to say that I know that everything is on track in terms of the completion of those accounts, and they're also due to go to the Audit Committee on the 11th of December as well. But as far as I'm aware, and in all of the conversations I've had recently, the audit is going smoothly, and so everything is on track.
Brilliant. Could I just have formal agreement by the board to delegate the approval of those accounts to the Audit and Risk Committee on the 11th of December? Does anyone have any objections? I can see nods. Brilliant. Thank you very much. I'm going to leave it there and I will hand over to Adam.
Thank you very much, Anita. My report is in the papers. I'll just draw out a few points as usual for emphasis. It seems some time ago now that the National League tables that have been in development for a while were reported, but it was actually since our last meeting. So this is the first time we can formally kind of put in those league tables and segmentation process. The trust has been put into segment 2 of 5. And in terms of the league table ranking, we are both the 19th highest ranked acute and specialist trust in the country and the highest ranked in the east of England. So real positive reflection on the organisation's performance. It is a holistic view that covers areas of quality and operations as well as finance and leadership and people. So it will continue to be refined. These league tables will be produced every quarter, and I expect a fair bit of movement quarter to quarter where organisations do improve in certain areas and others might get some challenges. There is an important override around the finances, so organisations that are not on plan or in receipt of external support are capped at segment 3. And so if other organisations are able to improve their position, some of those will move up into segments 1 and 2. We have now developed internally a real-time tracker through our excellent business intelligence team, and so we're able to track that. And I think going forward we'll look to reflect some of those metrics in our own performance reporting. So even on the interims, whilst we may not always be able to benchmark, because these are very much they're not fixed points, it's very much kind of quartiles, and so people will be moved up and down based on others. We can track our performance against what the NHS England and Department of Health and Social Care, as frankly our commissioners, are deeming to be the areas of importance. But that's really positive. And actually it's been backed up in the last couple of weeks with publication of ratings around cancer performance. And even more impressively, of all the trusts, I think 121 providing cancer care, we are ranked 2nd in the country. And that caused the BBC to come in and spend a day with a number of our cancer teams, and we got some really positive coverage a couple of weeks ago, actually maybe last week, across the BBC throughout the day. So it's very gratifying for the staff involved who have worked hard, and also those people who made decisions even back during the pandemic to maintain services when some other trusts backed away, and I think our local population are getting the benefit of that. Often when we talk about cancer, we'll think of Mount Vernon being our specialist centre, but actually far more people receive their cancer care through our Lister site and in the community than they do. So this is a holistic review of access to cancer care. There's been a significant amount of change going on, as the board have discussed previously, in the architecture of the NHS. And one big change has been the clustering of 3 of the integrated care boards into one. And as of the 1st of October, although technically and statutorily the 3 ICBs continue, that's Herts and West Essex where we sit, BLMK, Bedford, Luton, Milton Keynes, and Cambridge and Peterborough, they are now in effect operating as one, with the intention from the 1st of April they will formally become one. But they're now under a united leadership, so they have a shared chair and chief executive, and the senior leadership team executive and just below executive have now been appointed. We are already seeing the impact of that. We've received documents such as commissioning intentions for next year. The new leadership is bringing together providers across that wider footprint. I had a meeting with all the acute chief executives, which has now grown from the 3 in Herts and West Essex to about 10 of us. So there's opportunity to work and partner in a different level, and I think it offers some real opportunities. Underpinning that is our continuation of our place-based working with our health and care partnership that we are the lead for in East and North Herts. But a really important development, I think, is the setting up of ENHGP, or East and North Herts General Practice. And this is an alliance of all of the primary care providers across East and North Herts, with the intention of being able to speak with one voice, and over time potentially being able to take more of an active role in coordinating activities across primary care. This is really helpful for us because when you have so many bits of primary care with lots of different GPs, lots of practices, 12 primary care networks, 6 localities, it's very difficult to get that standardised voice. But that grouping have come together, and it means I think we can build further and stronger partnerships with primary care and make sure that their voice is very strongly heard in our place-based working. Anita has already referenced how hard people are working, and as well as the day-to-day management, we are now moving into the phase of planning. And the medium-term planning process has started. The government and NHS England are very keen that we move away from year-to-year planning that has been a feature of the NHS and funding settlements. They are looking to identify allocations and funding over a longer period, 3 to 5 years. And so the ask for us by the end of the year is to submit a 5-year strategic narrative with a 3-year detailed plan that sits behind the first part of that. And rather than just what we're doing this year and how will that change slightly next year, it's really to look at the signals in the 10-year plan with the shifts into the community, into digital, and moving upstream into prevention, so that we are demonstrating that not necessarily in year 1, but over that 3 to 5 years, we are really seeing some of those changes. The real positive is that it used to be kind of known within the service as a Christmas treat that we would get the planning guidance arrive on Christmas Eve, but it has already arrived, so it's a lot earlier. That's very positive. The challenge is the first submissions need to go in about 4 weeks from now, and so the deadlines are extremely tight, particularly bearing in mind the planning environment is so much more difficult in terms of change, 3-year plans, and a difficult financial environment. So whilst the planning guidance has come out, Martin and his team are receiving kind of some of the bits of the equation as they're trying to do the planning in terms of allocations and new funding models and tariff arrangements. So it is a really difficult task, and so that team are really having to hunker down, but trying to do it in a way that involves as many of our staff as possible, so we don't have a very theoretical plan, but it's really engaging as many of our clinical and operational leaders. So yeah, lots of work going on there, and we will I'll be talking about the process when, as Anita said, including our previous submission on capability, when we don't always have a meeting in line with those, how do we make sure we get the right governance in but don't delay? A couple of good news on estates updates as part of our kind of sustainability work and our green plan. We are about to implement a whole range of solar panels in our open car park. And these will form kind of canopies under which parking will be available underneath. But obviously while the work is done, that will mean that we have a limitation of parking spaces for our staff. And we know parking is a major constraint for those that want to use our facilities. We're grateful to the council of being able to provide us with some off-site parking down towards the old town. We've put arrangements in place to re-provide the spaces that will be lost there with a shuttle bus service to really try and not inconvenience staff that we either are volunteering or we will ask to move down and park there. We're also looking at our agile working arrangements to see whether we can have more people working remotely, both in the short term, but also as more of a normal pattern to again decompress. But that will save us significant financial outlay next year in terms of that sustainable energy, but also importantly, it being sustainable energy will help run more of our services in a more environmentally friendly way. And also very excitingly, we've just had confirmation of some funding that's been released to both expand our ambulance handover facilities, because we know that whilst our performance has been a lot stronger in that area in order to release vehicles back onto the road, we are limited by the space and the amount of patients we can take at a time. This will increase that space, allow for some redesign of the department, and so that's £2.3 million we've received. And we've also very recently heard, before I wrote the paper, of confirmation of funding to support developing our audiology development and creating a really great environment for paediatric audiology that we know and will see in our papers remains an area of backlog that we really want to get through as many children as possible. So some really great news on some funding. I want to just draw out vaccinations. We recognise that we tend to look to the other hemisphere to see what's coming our way in terms of flu, and we know Australia has been hit significantly hard with flu this year, and also earlier on in the normal pattern. That is now presenting itself, and there is some modelling that suggests we might be about to peak with flu this week. It obviously is a dynamic position. We have been encouraging as many staff as possible to have their flu vaccination. Justin himself, as medical director, has been out, and I've personally received my injection from Justin. We've got over 40% of our staff now vaccinated, and we are continuing to push and make that available for all staff, because we know that, and we've discussed at the board many times, including I've been moved by kind of David's story from his general practice of the impact flu can have on patients and staff. We'll often dismiss it as a bad cold, but actually if you properly have flu, it can be deadly. And one of the things we're circulating is a video that was made by the Community Trust of a very sad case of someone who really have had their life affected by flu in that sense. So we're really trying to do all we can. I've then highlighted a number of areas where we again are in for national awards. We've already heard from Tony, her award, and I'm delighted tomorrow I'll be attending with two members of our clinical staff the annual Health Service Journal Awards, where we've been shortlisted for Trust of the Year, and it's just great to be in that company, and great that we're taking two of our staff who have been recognised by colleagues internally as doing important roles to attend to represent the Trust at that event. And then a couple of bits just to say really around digital. We continue with our work and what is a really exciting project around our One EPR, where we will have an integrated electronic patient record system that not only will offer safety benefits and productivity benefits, it really gives the platform for a greater digital transformation across the organisation. But while we're doing that, we have now moved into electronic data management, or document management, should I say, and we've started to roll this out specialty by specialty, which in practice means that clinicians will no longer be sat in clinics with piles of paper notes. They have all been scanned, will be available to the clinician on the screen so they can easily find past results, past notes, and reduces the risk, although we've worked very hard on this and performed very well, the risk of having an outpatient clinic where notes aren't available to the clinician. And I know, again, Justin was part of paediatric rollout, which was our first wave, and conducted his clinics in this way as one of the first in the trust and found it a really positive experience. So lots going on in the digital space. Mark and team are working flat out to lead us through this way. But I will stop at that point, Anissa, I think, and everything else is written in the paper.
Thank you, Adam. Any questions or comments for Adam on anything he's talked about or anything in the paper? Nope. Thank you. A comprehensive report, Adam, and as you say, an awful lot going on at the moment. Right. Let's move on then to the nursing establishment review, and I'll hand over to Teresa.
Thank you, Chair. I'm very pleased to have our nursing safer staffing paper at the board. As we know, this is a quality standard that came from the National Quality Board in 2016, and we're just about to have a new National Quality Board, and I'm sure they will reinforce these standards of high-level visibility for safer nurse staffing across all of our areas. Just a couple of points, if I may, Chair, to draw out. I think the paper is very comprehensive. It has been to our Quality and Safety Committee and had a thorough sort of outing and testing there. But for maternity, we will have a full evidence-based review of our maternity staffing via Birthrate Plus, and that's just being commissioned at the moment, and that's the sort of best-in-class standard for midwifery. The purpose and the scope of this is really to make sure that we are managing and triangulating clinical acuity, bed bases, professional judgment, and layering on safer nursing care tools and care hours per day, the two main evidence tools that tells us have we got safer staffing in our clinical areas. I think it's really helpful that you can see in this paper where we will have hotspots and vacancies. We've talked for quite a while about care support workers. I'm really pleased to report, but not in the paper, that we've completely more or less closed that gap, and super grateful to the support that I've had from Penny and Martin to make sure we're in a better position. But you'll see in the paper that there's been a bit of a hotspot for the emergency department's vacancy rate, and that as well has closed down over the course of us writing this paper. Could you believe it? I think it's also helpful to understand that we have seasonal variation. So if we think about our respiratory ward and our intensive care, we've just touched on flu, and Adam has just explained to us the likelihood of what's likely to impact over winter, making sure that we've got that complete and utter seamless working across intensive care and respiratory, and sharing some nursing resources. So you'll see some coverage of that in the paper as well. I think I'll probably stop now and take questions, but just to finally reassure the board that this isn't just a once in a quarter document that goes to various committees. It's a very live and dynamic process. And 3 times a day, senior nurses, ward managers and duty matrons will be reviewing clinical acuity and making good judgment decisions on where our staff should be based, running alongside the strategic priorities. So I'll stop now and take questions, Chair.
Thank you very much, Teresa. David.
Thank you. Well, I think Teresa's made some really important points. This is an ongoing process. It's a daily process which has been going for years. And whenever I read it, I feel a high level of assurance that we are looking at our staffing in such a complex and detailed way. So I think the board should take a lot of comfort from this report. The only other thing I would say is below this, there's a human aspect where people turn up to work and all of a sudden they get shifted somewhere else, perhaps somewhere they're not used to working, or with colleagues they're not used to working with. So it does cause, safety at our level is incredibly important, but it does cause disruption, reduce efficiency, and isn't ideal from a people point of view. So I just want to remind us about that aspect of maintaining safety. Our role, of course, ultimately is to maintain safety. But thank you for the report.
Thank you, David. I don't know if you wanted to come back on that, Teresa.
If I may, I think David's absolutely right, Chair. And, as the human factor, if I think I'm working on AMU and I'm asked to move to the respiratory ward and I've not worked there before, and we're seeing increasingly the need to sort of manage those conversations and be supportive. And if somebody has moved once in the week, hard to make sure it's personal, that we're protecting the individual and really sort of supporting them in any move they make. And equally, we're acknowledging where people have gone above and beyond. So going to help colleagues or worked a couple of extra hours or did something that was really phenomenal or really accepted that actually my staffing's okay in this area. I shall go and work in one of the surgical units, and recognising that through good care events as well. So yeah, you're absolutely right, David. It's so important to get that balance right.
Great, thank you. Teresa, I had one question, and it's more sort of a reflective one, I guess. I mean, one of the things that that we all often hear is that part of the reason for you know, our establishment numbers being where they are is because we are seeing increasing acuity of patients, both in ED but also in inpatients. Is obviously you are monitoring this all the time. Is that your opinion as well? Do you have a view on, is it true that is part of the challenge that we're facing?
I think you're absolutely, it's a great question to ask, Chair. So we're seeing, if you like, higher numbers of tracheostomy patients. They are much more high acuity, and we're doing a good piece of work to try and make sure across our surgical wards and our medical wards we're training and skilling up staff so that they can look after these patients effectively and safely. We're also seeing higher numbers of patients requiring non-invasive ventilation, and that's certainly putting some strain on our wards in the 11s. And again, in maternity, we're seeing higher acuity, higher levels of C-sections, and indeed sometimes more complex women who will unfortunately have some side effects of a C-section being activated. So I think it's fair to say we are seeing higher levels of acuity across most of our domains. But what I would say, we have lost some beds for a wee period of time there whilst we were inputting emergency call bells. They are now all open, so thank you, Kevin, for putting those beds back in action for us, and that sort of helps us spread some of the acuity. I think the role of the duty matron is vital. Walking the patch, checking the acuity, observing the staff on duty, looking for the teamwork, working back to back with the specialty teams, and sometimes moving staff or patients for that matter to the right location of care.
That's really helpful. Thank you, Teresa. Right, any more questions for Teresa? I don't see any more hands. That one was for noting, so thank you very much for your report. Let's move on then to learning from deaths. Now, this one is an assurance paper. There is substantial assurance is the recommendation, but I'll hand over to Justin to tell us about it.
Thank you, Anita. Just a couple of points from me, and then I'll hand over for questions. So you'll see that the report is a little bit longer than the one that I normally present, and that's because it contains a summary of deaths from 2024 to 2025. We are going to do some work on the format of this report because I recognise there's quite a lot of information to read in there, and hopefully we'll bring a shorter one in future. I think that our data demonstrates that we provide good care for the most part. We've got a lower than expected mortality as a trust. This doesn't mean that we can't do better, and we always seek to learn from every death. And that's the whole reason that we look at this in so much detail. Going forward, as we go into the winter, Adam's already spoken about predicted levels of flu this winter. We have a number of concerns, and I think my biggest worry as medical director is really the concerns around flow. If the hospital becomes extremely busy over the winter period, then we will see slower flow out of our ED department. And we know from the Royal College of Emergency Medicine data that when that happens, there is a likelihood of mortality increasing. So we've put lots of things in place looking towards winter in order to try and keep our patients as safe as possible. But if we get into that logjam situation, then I guess that's my biggest worry as medical director about mortality across the organisation. I'm really happy to take questions on the report if people have them.
Thank you. Very comprehensive paper, and I think it's already been through at least QSC from memory, and also the Mortality Surveillance Committee as well. Questions, Karen?
So the first thing I wanted to say was I found it a really helpful paper and extremely easy to understand for somebody that hasn't been to Quality and Safety on this to see this particular report. So for that, I want to say thank you. And I got a lot of assurance from the paper as well. I did have one question, and that is, in terms of our learning, we do continually get comments about the way we communicate with our patients and their family, and I know it comes up in complaints at times as well, and of course it is reflected in here. And I was just wondering what more you think we can potentially do about that particular issue. I know it's one that we've given a lot of thought to. I was also wondering whether, with the rollout of our new systems as they're coming into play, so management, which Adam referred to in his update, and with the introduction of the new EPR, whether you think that might actually help us with improving our communications.
Okay, two very meaty questions. Thank you, Karen. I think that the thing that we hear time and time again is that patients want to be involved in decision making around their care, and they want to feel that they are a partner in that decision making. I think that lots of our medical teams do that well. I think sometimes it doesn't happen as well as it should happen. It's something I've been talking about a lot with medical teams. It's something that I'm asking them for help with. We have to get it right every time. I think the stress will always be when teams are extremely busy, whether they can do things as well on their worst day as they can do on their best day. I think as an organisation, we owe it to our patients to communicate, to involve them in the decisions around their treatment, and to make sure that they understand what we're doing. I think the days have gone of doctors being able to be paternalistic and making decisions for patients. I think that we have to be equal partners within that. Question about the EPR. I've gone through my career as a doctor, and each time I've come to a new digital system, the hope has been that this will make life easier. It has happened with a couple of things. PACS, X-ray system, does make life significantly easier for doctors. There is other stuff that has also made life easier. We haven't yet in this organisation seen an EPR that will make life easier. I've been out to Germany to have a look at the product we're about to install, and my fingers are crossed, and I think this actually might be the time that life becomes a little bit easier because of digital. If that happens, it gives people more opportunity to spend time communicating, less time writing discharge summaries, less time feeding the beast that digital can become. So I'm really hopeful that what we're about to implement over the next year or so will make all of our lives easier and will allow us to do our jobs better. So I guess I'm an optimist, and I see this as a real positive for the future.
Thank you, Justin, and thank you, Karen. David.
Thank you. Again, this is another paper which I think is really fundamental and important. It's learning from death is a national process which we've been undertaking for a long time, but if you're in a healthcare organisation, you should be looking at everybody who doesn't do well, even though most of the time our performance, what we've done, comes out good. So thank you for the paper. We have looked at the QSC. I do have a question about the National Emergency Laparotomy Audit, which is NELA, and it may be too much detail for the board, but I reported a year or two ago that after a long period of time, our performance at NELA had improved. But when I did a ward round with the team about 9 months ago, they were clearly frustrated that NELA patients' acute abdomens were not being prioritised in a way they felt should be. So I think we've got a structural problem in theatres that is stopping us do better at this audit. But maybe we could just have a few comments and pick that up outside the meeting.
Okay, couple of brief comments on that. Interestingly, there's been an editorial in the Journal of Anaesthesia about prioritisation pathways through theatre. And the short version of the editorial is that you can choose pathways that you wish to prioritise, and we've done that along with the national programme, both for NELA and fractured neck of femur. But there is always a downside to doing that. There is a set flow that can go through our emergency theatres, and when you prioritise one pathway, you deprioritise another one. So striking that balance in theatre flow is a really, really difficult ask. We know that fractured neck of femur, patients with fractured neck of femur do better if they're operated on earlier. We know patients with acute abdomens do better if they're operated on earlier. But we also know that several other groups of patients do better if they're operated on earlier. We don't have the ability to run more emergency theatres than we currently do. And I guess the art in this is getting that balance absolutely right. And a number of groups of surgeons feel that they want their patients to go through the system faster than they do at the moment. I don't have an easy answer to this. Interestingly, we were discussing whether specific other groups of patients should be prioritised for operating on recently, and we had a discussion about it. And what became very clear is that if we did that, there would be a knock-on effect on others. So I want to continue to have this discussion and debate about how we prioritise patients through theatre. But I also want us to be cognizant of the fact that when one prioritises one group, you deprioritise another.
So I guess
difficult.
I guess the board has to accept that we will not improve our performance in every audit.
We will push as hard as we can, and we will do the very best that we can. And I guess by increasing our productivity and our throughput, we may be able to make some difference to that. But we cannot prioritise one group to the detriment of another.
Thank you, Justin and David. And yeah, I think we understand that this is an art, not a science, in some ways, in terms of getting that balancing point. Teresa.
Thanks, Chair. I just wanted to make a quick point about vulnerable patients, and I'm sure the board is aware, but there is really excellent work that occurs between our safeguarding team in relation to learning disabilities patients who die, and our mortality team, and it's something that we do take very seriously, and it's shared across both committees and indeed externally across Hertfordshire. So I just wanted to thank Justin for continuing that joint work.
Great, thank you, and a point well made. Diana.
Thank you, Chair. Justin, I just wanted to say it was an excellent paper. I just want to echo what Karen was saying. It's just very clear, particularly helpful for people who are non-clinical. My point was really just about, or question really was just in relation to the health inequalities and deprivation section. You mentioned obviously that we do have relatively low levels of deprivation in our geographic area. I think it's really helpful to see that you will be working with the business intelligence team to help to really kind of get a better understanding of health inequalities and deprivation in our area. I'm just wondering whether in some of that work, when you get that learning, how you're going to make sure that it gets spread across to as many people as possible across the trust, because there are going to be some areas where, where you might not necessarily immediately think there will be some learning that could be shared, but there is. So for example, I can see where it can overlap with EDI issues, for example. So I'm just wondering what approach you're looking to take.
So we've recently started a health equity group within the trust, looking at health inequalities and how we can do more. And there are a number of issues that are coming up to the surface. If you look at the mortality data, then the number of deaths by quintile of deprivation is not we're not seeing more deaths in the most deprived quintile than we would expect to do, which is a positive. However, we know that the people in the most deprived quintile will be dying very significantly earlier. We also know nationally that the data about not just life expectancy, but healthy life expectancy actually has deteriorated for patients in the most deprived quintile. So we're looking through the lens of the Health Equity Group what we can do more. I was actually in a seminar earlier on this morning looking at homelessness, and we're going to start to talk a little bit more about that across the organisation. We're also looking where we can achieve the most through the Health Equity Group with the limited resources we have. And there'll be a few things coming to TMG as asks over the next few months of things that I think we can do that probably won't be very expensive, but will make a really significant difference. And the Health Equity Group are talking very much about those priorities. Interestingly, when we had our recent seminar on poverty, what we saw was that actually things have improved very dramatically for our population as they age, but actually we haven't had the same impact on children and young people. And we want to look through the lens of the Health Equity Group how we make a difference to that. So there's quite a lot happening in this area, and we're looking at the data we have in significant detail so that we can make sure we move forward with the things that will actually be the most effective.
Thank you.
Thank you, Justin, and completely get your point that we are very fortunate in this part of the world not to have very high levels of socioeconomic deprivation, but that doesn't mean that they don't exist, and where they do exist, they're just as important as they would be anywhere else. And in fact, the problem is that sometimes when when you aggregate data, you don't necessarily see it so easily. So really applaud the work that we're doing. I don't see any more hands. I had just one very quick question, Justin. You mentioned in your paper a sort of a medium risk around medical examiner capacity and funding. I don't know if you could say a little bit more about it. I mean, it's medium, so you obviously see this as a risk. Could you tell us a bit about it, please? Thanks.
Yeah. So at some stage last year, we were obligated to take on medical examiner responsibility for all of the community deaths. There are more community deaths coming through than we expected, whereas the funding for the medical examiner program was relatively generous at the start of the program. As often happens with these things, belts have been tightened. We need to make sure that we've got the right resource to do this. We do not want to leave families waiting for a decision following the death of a relative. We need to get on and do that work well, and we need to do it rapidly so that families can move on in their lives. I've got a meeting coming up in the next couple of weeks with our lead medical examiner to look at what more we can do. We may also need to go back to the regional chief medical examiner in order to make sure that we're getting the right amount of funding for the service that we're delivering across the trust.
Okay, thank you very much for that. Okay, if no one has any further questions, as I said at the start, this is a paper with an assurance level that is proposed as substantial. I think several people have commented on its comprehensiveness. I don't know if that's a noun, but I think you know what I mean. Can I ask for board views? Are we comfortable with an assurance level of substantial? Would we like to change that? What's our position? Okay, Shani, if we are happy with substantial, can I get some nods, please? Nods? Nods. Okay, I'm seeing nods. Lovely. In which case we will endorse that assurance level of substantial. A very good paper, Justin. Thank you very much. Let's then move on to board assurance framework, which is Stuart. This one also has an assurance level of partial, but I'll hand over to Stuart to say more.
Thank you very much, Chair. So before turning to the Chief Kaizen Officer and the Chief Finance Officer for the two spotlighted risks, just highlighting a couple of key points. So as the cover sheet sets out, FPPC has supported the financial constraints risk score moving from a 16 to a 20, and that's reflective of the reliance on non-recurrent savings to stick to plan. I would also highlight the context for this is important to interpret this prudent change. So the trust is in band 2 of 5 in the National Oversight Framework, and only 13% of general acute trusts are in these top 2 bands, in the context that 87% are in lower bands, where acutes are particularly struggling, staying within financial plans. So that's the first, and that's the only proposed risk score change. However, Digital Committee were going to review the digital risk score. The proposal was to remain at 16, despite a later 1EPR go live date. However, Digital Committee hasn't met in November and will be meeting in December, so we don't actually have an update on that one at the moment, but just highlighting that. And as you've mentioned, Chair, the overall recommendation remains at a partial assurance rating, and that simply reflects that we've got 5 new BAF risks. So you wouldn't have new BAF risks if the board was fully assured. But it does reflect that the system instability and financial constraints risk scores have increased. But to counter that, I would also say the cover sheet does set out a lot of really positive progress across a range of BAPs.
Great, thank you, Stuart. Is Martin going to speak to us about one risk and Kevin the other? Is that the plan?
That's the plan, yes.
Brilliant, thank you.
So I was going to turn to Kevin first for the BAF 11, if that's okay.
Thanks, Stuart. Thanks, Chair. So BAF Risk 11 is all around sort of how we increase our change management capacity and capability so that the organisation could become much more adaptive and agile, so that we can basically seize the opportunities that we need to in terms of transforming services and care as we move forward. We had a comprehensive review of this risk at the People and Culture Committee at the beginning of the month, and we've done that alongside. There is a natural variation in uptake of change management across different leaders, but that's a natural part of the adoption curve. And what we were reflecting was that the trajectory that we see ahead and the progress that we've made over the last 18 months would suggest that whilst we still remain at a score of 16, given the level of increased activity and insights and learning of the organisation and how that's reflecting amongst teams, we see that that score will reduce over the next sort of 6 to 12 months particularly, and we'll see then another significant sort of score, doing the right things, and assurance that they're being completed in a timely way. I'll stop there for any observations or questions.
Thank you, Kevin. Are there any questions or comments for Kevin on that particular BAF risk? I don't see any hands. Okay. Thank you, Kevin. I think that we'll say that that's acceptance of your point of view. I think that sounds great. Let one.
Thanks, Anita. So BAF risk 1 relates to our ability to invest in our capital kind of infrastructure to kind of support the delivery of our kind of service. So probably talk about that across 2 or 3 different kind of dimensions. One is just delivery of kind of this year's plan, the impact of then some of the changed capital planning guidance we can see for 26, 27, and then thirdly how we're kind of responding to that. So I think our capital programme for this year continues to make good progress. That's a programme that's £31 million kind of in total. Some of that funded from kind of internal allocations, but also a big chunk funded from national PDC programmes on there. And I was mentioning a couple of those already in terms of ambulance expansion and also audiology. I think it is important to note that the successful delivery of the programme will see the 4th consecutive year of over £30 million per annum investment in our infrastructure across medical equipment, across backlog maintenance, across kind of digital and strategic schemes. So over £120 million worth of investment over 4 years. That has made a significant impact within the organisation, but of course within the context of a diverse and at times aged estate, that remains an ongoing challenge for the organisation. The way that capital will flow around the NHS kind of moving forward into 26, 27 will change. There is a 4-year allocation of kind of resource that's been committed to the government, so that is expected to help with longer term kind of planning, and providers will receive now specific allocations based on kind of calculations of depreciation and critical infrastructure risk rather than kind of distributions of system-based kind of shares. The amount of money we'll get from that will probably not change materially, but I guess there is a degree of autonomy that we will enjoy from that may help us more flexibly deploy those kind of funds. I think regions have been notified that they will hold centrally slightly larger allocations that they will be able to kind of prioritise around larger impact schemes across their regional kind of footprints. I think this represents an interesting kind of opportunity for us, and certainly something that we could use in order to progress maybe larger strategic schemes that we have kind of struggled to embed within our annual allocation. So I think, for example, of our aspirations to refresh our paediatric ward estate on there. So I think that's an interesting kind of opportunity for us. In terms of how we make the most and access that kind of planning guidance kind of going forward, our critical infrastructure kind of group have been doing work over recent weeks to take our 5-year capital strategy, which we agreed kind of last year, and break that down into a series of annual areas of kind of focus kind of for us. So certainly in our weekly business planning group, we reviewed the latest iteration of that on Monday, and work will continue over the coming weeks to be able to present something to board and FPPC on the 15th of December for review and consideration. But again, I think that will be a difficult balancing act that we'll need to work through as a board in terms of how we focus resource on BAU, keeping the lights on, so to speak, but also the needs to kind of invest in transformational and strategic schemes as well. So a tricky balancing act on there, but maybe I think probably a little bit more room for manoeuvre in terms of capital than certainly we can see on the revenue side. So hopefully that kind of continues to help the board to understand that particular kind of risk on the BAF.
Thank you very much, Martin. Any questions or comments for Martin regarding risk 3? No? Okay. Thank you for that, Martin. And I think, as you say, I think it's worth us recognising things like the fact that we actually have been annually spending a reasonable amount of money on our backlog maintenance and so on. And I think that's actually a real achievement for us, given the circumstances we're in. So absolutely well done on that. Okay, just before we leave this paper, obviously the other BAF risks hopefully have all gone to committees, and therefore there have been opportunities for discussion in other arenas. But I wonder if anyone had any other comments regarding any of the BAF risks. Karen.
I've got a high-level comment, actually, and it's to do with the partial assurance rating. And in terms of this paper, because I think it depends on what we're trying to get from the paper. Because from my perspective, what we have with our BAF, as we now have it, is a document that isn't just a document. It's a living thing that goes across all of the committees and is discussed in detail. We go through all of the information and we take it all incredibly seriously. And it has changed throughout the year. You can see that. And so I actually think it works well in terms of when you're looking at risk management across the organisation. It works well in terms of what is it we're trying to achieve as an organisation, and are we focusing on the issues that are causing us to consider how easy it is going to be to hit some of those strategic objectives. So I'm not saying I think we should increase the rating now, but I do think it is one that we should reflect upon, because I think within the document we are supposed to score our individual risks, and we do those and we take them very seriously. And then as a board we come back and we use our BAF to help us as we move forward. And I know we will refresh the document again in March, April. So to my mind, our risk management has come on enormously as a trust. And I just think it's maybe one for us to take away and reflect upon. Are we scoring the risk for the trust in terms of partial assurance, or are we scoring the processes that we are going through? And how much assurance do we get from this document that we understand the risks that we face as an organisation and that we are doing our best to mitigate them, with the understanding that some of the risks, like, for example, in terms of capital or trying to change, are risks that are always going to be there to an extent, and to mitigate them is the best we can do. So it's probably not something for a big debate at board, but I did think it was worth just reflecting upon that, and to say thank you to Stuart for the work that goes into this area. It's I know you beaver on behind the scenes, but it is a really important piece of work.
Absolutely. And actually, I'm really glad you said that, Karen. I'll bring Jill in a minute, but I actually had exactly the same thought when I was reading this, that actually I think our processes aren't bad at all, and it felt a little bit under assessed in my view, but very happy for us to, you know, it's a good conversation for us to have. Let me bring Jill in here because she may have a view on that.
Thank you. I agree. I think that it's become far more dynamic, and that's really commendable. And that's the sort of journey of maturity, isn't it? And that's good to see evidence that, you know, we're on that journey, and that is getting more dynamic and therefore more effective. I just wanted to share my recollection, I think, from discussions of committees where elements of this have been discussed recently, is that an aspect that focused on partial assurance was related to, you know, the variance of the use of the assurance scores on controls. And I think that again is an issue of maturity and familiarization. And we're clearly getting better at that, but that is my recollection was a key factor for why at the committee level we talked about partial assurance.
No, absolutely, and you're right. I think it just feels like we're a more mature organisation, and we're having slightly different discussions about this. So I wonder if I could get some thoughts then from the board. We are down as partial. Some comments have been made that maybe that is under assessing our level of assurance, and we could potentially go to reasonable, which is the next level up. Equally, we could stay where we are. I wonder if I could ask for a show of nods. I think probably not. I think you're all on one page, so I can see you all at one go. So if we are in favour of raising the insurance level to reasonable, could I have some nods? 1, 2, 3, 4, 5. Yeah, I'm seeing a majority there. That's a good number there. Okay, what if I could have nods now for people who would prefer to stay at partial? 1, 2. Okay, I think that the ayes have it, as it were, and I think therefore the vote is that we will increase the assurance level on this one to reasonable. If everyone is, unless anyone has any strong views, we must keep this under review, and we must always make sure that we may remain comfortable. But I think Karen put it very well. To me, it's, are the processes good? And I think we probably are in a lot better place. Kevin, you wanted to come in.
I was just going to ask, Chair, whether or not the question should be, are we happy to enhance our risk appetite rather than change the risk on the risk itself? I mean, I suppose the risk is the risk, and we've calculated what it is. We understand that the risk is there, and we understand that there are mitigations very difficult for us to actually achieve them. It's whether or not the trust board realises those limitations and accepts that they can enhance the risk appetite of the board, which would then maintain the risk scoring itself, if you see what I mean.
I do. I'm going to bring Stuart in because I think we're supposed to be talking about risk appetite a little bit in our board seminar in December. But Stuart, I don't know if you have a view on that.
I'll probably keep the assurance more to the process element, but there is, as has been said, we're going to be talking about risk appetite in under a month. So it'd be a great opportunity then, Kevin, to talk about that.
Yeah. Okay. I think based on the nods of the board, I think our board view is that the assurance level could be raised on this, on the processes around our BAF, could be raised to reasonable. And let's have that conversation about risk appetite next month in the board seminar. But want to echo also Karen's comments. I mean, I think this is an area that has really improved in maturity, and I can see the difference. So very, very good, very great thanks to you, Stuart, for all your hard work in this area, and indeed the committees for really taking their responsibilities diligently. I think if we're in a better place, if our processes look better, it's because we're getting smarter at this, and that's really good to see. Janet, did you want to come in?
No, that was an accident. I meant to do a thumbs up. And
All right, that's brilliant. Okay. Now, what I would suggest we do, actually, no, I wonder if we could just go on just a couple of minutes more. I'd like to take the next paper and then we'll stop for a break, if that's all right. As I mentioned and we're all very aware, we're obviously just emerging from 5 days of industrial action from the resident doctors. This next paper, therefore, is particularly relevant, I think, to some of the concerns that our residents feel. So I think I would quite like to do this one before the break. Penny, could I come to you, please? Thanks.
Sorry, I was on mute. So this paper is shared with the board to give an overview and hopefully assurance around the 10-point plan. So just to recap, and so we're on the same page, the 10-point plan to improve the lives of resident doctors was kind of developed over the summer, and from September we've been looking at action against each of the 10-point plan actions. Some of them, one or two sit with NHS England, but the majority sit with trusts. In addition to that, there was a baseline assessment undertaken in September, which was slightly different questions. What I've shared with the board here is action and progress on both of those. So to come to the baseline plan, in September, we were around middle of the road. We had a 62% kind of completion rate on our actions. We've moved on considerably since then, but I'll come back to that. And you've also got update on actions around the 10-point plan. And they were things like facilities that we provide for resident doctors, including car parking and eating facilities, resting facilities, as well as rotas, annual leave, mandatory trainings. There were a whole range of things that were causing angst to resident doctors that have been embedded within the plan to make their lives better. What I've shared here is action against those. And even since the plan was shared with board, we've moved on again. We have a senior sponsor in myself. We also have a senior clinician who runs our kind of working group, which is a multidisciplinary working group, looking at action against all of the other elements of the 10-point plan. We have a subgroup in facilities because there are lots of facilities type things. And we have work underway against everything that we were either needing to progress on or hadn't quite managed to achieve. So this is shared really to give an overview, to give a bit more detail and to provide assurance that we are actively working towards all elements of the 10-point plan and to share with you our current progress. I think that's probably all I'll say. I'll take questions. I know that we've had various discussions before. Sorry, Chair, one more thing. It goes to People Committee first as a standing agenda item and then comes to board. So that's the governance route.
Great, thank you, Penny. Just to be clear, you said that at the time of the paper, our assessment score was 62%, but that you thought it was higher. Could you give us an estimate of where we are now, please?
Yeah, so a lot of the I think the next baseline will either be in December or January. So we'll run that again. Some of the facilities things. We're looking at demand and supply of rest facilities. We'd marked ourselves down, for example, on not providing hot and cold food. Actually, we think we do provide hot and cold food. In the initial assessment, we'd said no. We've also made some improvements in our rota compliance. We're working on automating that, though, because at the moment, it's kind of dispersed in among rota kind of coordinators in the trust. We're looking at the viability of bringing that together. And mandatory training, we've signed a memorandum of understanding that says, a bit like a passport, it follows resident doctors as they move. We're working on compliance around that. So we said we would do it. And then when we've gone back to check if that's happening, it's patchy. So we're working on consistency. So there's some areas where it was right to say no at the time, or it was right to say we're working on it, and now we've delivered more on that. So I'm hoping that the 62% will go up, hopefully significantly when we run the baseline assessment again.
That's great. And that will be in December, you said?
Yeah, indication at the moment, it's run by NHSE, indication it's December or January.
Okay,
yeah.
Perfect. Thank you very much. Jill.
Thank you. I mean, obviously, we've had the chance, as Penny's mentioned, through the People Committee of looking at this in detail. And so my question isn't at all about, you know, the content of this plan, all of which, you know, necessary, important and very reasonable issues that we're working with some pace to try and address. So all of that's good. My question was a broader one, really, about whether the executive have seen or noticed or become aware of any unintended consequences, I suppose, for other professional groups as a consequence of this focus.
They haven't been raised with us, and I suppose I'll ask Justin in terms of views. I think what it's done, actually, some of the things that we're looking at to improve for resident doctors, some are very specific to resident doctors and some are more broadly, they will benefit everybody. So making sure that we have rotas out benefits everyone, making sure that we have policies that we stick to and consistency benefits everybody. So actually, I think there hasn't been as much pushback, Jill, because where improvements are felt, they're felt by everyone, even though we're expected to report on the resident doctors focused on those. Some of the improvements actually benefit a broader range of colleagues. But I can see hands have gone up from our two clinical support execs.
Great. Yeah, thanks, Penny. Let me bring Teresa in because she was quicker off the mark than Justin.
So actually, Jill, locally, there's not an awful lot of dissent. I think everybody sees the merit of doing this. We feel that, you know, our doctors and residents need the best environment to work in. But regionally and nationally, there's quite a lot of feedback from chief nurses saying, why can't we do this for nurses and midwives and AHPs? If it works well for doctors, let's roll it across the other professions. That's certainly what I've heard.
Yeah, thank you. And Justin.
It's a bit worrying, but I was going to say something very similar to Teresa. I see getting this right for one group as a blueprint to getting it right for all groups. I guess the only other comment I would make, the bit that makes resident doctors slightly different, is their need to move between hospitals and their lack of control as to where they go. So if you're on a training program in the east of England, that's actually a really big region geographically, and you could be working in Norfolk or Norwich this month, and in 6 months' time you could be moving to us in Stevenage, and that's really difficult from a life perspective. The travel around that is really difficult, and therefore if you don't have somewhere to park when you get to the new hospital, that's hard. If you don't have somewhere to stay after you've had a really taxing night on call and you have to drive home 40 or 50 miles, that's also a real problem. So there is a slight difference in this group compared to other groups. They may well live a very long way away from the trust because of the way they rotate. But I think if we get this right for one group, we can get it right for everybody.
Yeah, absolutely, Justin. Thank you. Any other comments? This is for assurance. It has been proposed as reasonable. Are we happy with that assurance level? Yep. I'm getting nods. Great. Okay. We will confirm that assurance level. Thank you very much for the paper, Penny. That's really helpful. And we look forward to seeing ongoing progress. Right. I make it 2 minutes past 11. I'm going to suggest we take a 10-minute break at this point and we'll restart at 12 minutes past 11, and we'll go straight into the IPR at that point. See you shortly. Thank you. point of our agenda, which is the Integrated Performance Report. And I think Teresa is going to take us through it today. Thank you.
Thank you, Chair. And before I go into the 4 quadrants, I'll just do a 1 minute recap on the oversight framework, which we touched on earlier. So as we know, as a board, this is a systematic approach for performance monitoring for NHS trusts and ICBs, but it's also to improve public accountability, as we're aware. And it really sits across 4 main areas. So the performance metrics that we have in our pack, and we can see where we sit on those. The segmentation that Adam touched on earlier, and the fact that we're in segment 2, and how, as you go down those segments, and we don't intend to do that, you then have assisted support, or indeed intensive support. And then there's the area of capability assessments, which trusts are obliged to submit and provide assurance and evidence of where they are sitting. And then finally, transparency for the organisations and the public. So it's really pleasing to see that in our report, which we can see where we benchmark with peers as well, and our ratings across those domains. Now, interestingly enough, in terms of the CQC one that we can see there, this is really because we sit with many other organisations in the RI category. However, as you're aware, Chair and colleagues, our ambition is to get to CQC good across the safety and other domains. So I'm sure in time we will see that change. But rather pleasing where we sit for our infection control rating, which is very good at the moment. And that leads me into the quality section, which I'll go through first, just for escalation, if I may. So really solid, good performance across infection control, both in MRSA and in C. diff, and pleasing to note, and actually really good progress compared to last year as well. Sepsis and ED, I think a really strong performance there across all of our domains, and a bit of a blip across our ward numbers, but we've got a close line of sight into those. Justin earlier was talking to me about the really exciting prospect of having CTP scans now introduced for stroke patients. And really what that does do is it allows our patients to have that greater accessibility to a much quicker way of salvaging the ischemia that can be caused by a latent stroke. So we'll follow that progress through QSC and see how we start to move through the SNAP ratings and get back to where we should be. Again, in maternity, we touched on this earlier, higher acuity, higher volumes of C-sections, and also some patients have had major obstetric hemorrhage situations, all extremely well managed and no mortality there. But that just gives an indication of that increasing activity and acuity in maternity. PALS and complaints, never too far from my mind or anyone else's mind. A huge focus in trying to put additional support into PALS, but rather pleasingly what we're seeing that has moved from this week is a big ownership piece in the divisions, but particularly in plan care, where we've got our highest reported numbers. So that's starting to move in the right direction. And our next piece of work is getting to the heart of why we're having complaints, and also speaking to patients in much more real time and preventing complaints. If I can move on to the finance section now, which I'm really looking forward to actually. I have been briefed by Martin on our current position, and whilst we have agreed as a board that we would deliver on a financial balance, clearly there are pressures in the system. So Q3 and Q4, you'll see in the pack where the differentials are, and there is an absolute need to make sure we maximise our opportunity with our CIPs. And of course, by not doing that, what we may have to do is to make non-recurrent actions, take them into play for our financial place. And that's not really ideal for any position to be in. So I guess this is a call to arms, not just for colleagues who are running those areas, but our divisional leadership teams, but also our delivery board, to make sure that we capitalise on really making our best efforts for Q3 and Q4. In the pack, you'll also see that there's been a big drive for CSW recruitment. We've done very well there. And again, colleagues would remind me that what we can't do is appoint to every vacancy and then still have a run rate of temporary staffing. So much tighter controls over those areas. It's going to be vital. If I move on now to operations, so operations, you'll see, I think the main flag here is that winter is with us, winter's here, and you can see that sustained pressure over the past 8 weeks in our ED performance, both for 4-hour and 12-hour. Despite that, we've done pretty well with ambulance handover, which is a good indicator, and we're not too far off our 4-hour, so just want to make sure that we drive that as hard as we can. A real line of sight into every 12-hour trolley wait now, and in fact a real escalation momentum has developed over the past couple of weeks, led by Lucy, Justin and myself, to try and eradicate 12-hour trolley waits in ED. We have discussed earlier on our community waiting times challenges, and that's something that's very close to our heart from a quality perspective and also an access perspective. Really pleasing to note that our 3 chief operating officers across HCT, HPFT and Lucy are meeting to develop a plan that is short, medium and long-term sustainable for those children as well. And then I guess finally just to say great news on cancer, as we discussed earlier, and Adam expressed 3 out of 3 on the targets, and a change of focus and an up pace on RTT as well, with some changes across Lucy's team as well, which I'm sure we'll touch on. If I move over to people now, really solid results around people in terms of making sure that we're tracking Statman training and making sure that appraisals are done. We know that when our appraisals are done, it lifts everybody's mood. They feel positive about their working environment and it drives better energy across our organisations. Holding our position around retention rates, which is really important in all our clinical areas, but also a real focus and forensic lens on our sickness and reasons for short-term sickness, some of which has been related to work-related stress. And again, that links back to the activity and acuity that we're seeing in winter. So I think I'll probably stop there, Chair, if I may take any questions.
That's great. Thank you, Teresa. And that was really, really nicely brought together. Questions, comments, if anyone wants to add any additional information that they think the board might find helpful, let's just open it up. Janet.
Thank you. Yeah, thanks for that really comprehensive run through. A question I had, although we're doing quite well on agency spend and kind of keeping things looking like they should be and turnovers looking reasonably healthy, etc., we still seem to be really struggling around medical locum cost, particularly in unplanned care, and that's something we did discuss, I think, a couple of times at the People Committee. I guess I'm still curious about where are we about, you know, forensically understanding how job planning's working, how that's kind of allocated, because we are recruiting, but we don't seem to be having the impact that, and obviously that's a very kind of high cost area of agency spend.
I might defer this answer to Justin, Chair. Yeah.
Thanks, Justin. Thanks, Teresa.
So I'm going to have a go at answering, and Martin may want to come in. We are seeing a drop in our bank spend in unplanned care, but there is still more to do. We are absolutely doing the forensic examination as to why the spend was so high. Lots of it relates to less than full-time employees and the way that we roster less than full-time employees and ensuring that we spread that rostering load throughout the week. I know this is getting very technical, but it's about our understanding as an organisation of what our obligations are when staff say that they want to work less than full-time. And the short version of that answer is that we have to allow that, but what we don't have to do is allow everybody to work on the same few days of the week. In other words, we need to spread the rostering across the week. That then drives lower bank utilisation, and we know that every bank member of staff costs twice as much per hour as a standard member of staff. So we absolutely have to get that bit right. I think we heard a little bit earlier on this morning about the consolidation of our rostering function, bringing it all into one place. And I think that will drive a better understanding of how to do it well. But please be assured this is something that we are working on really hard, because we realise that there's no point doing all the other work we're doing to save money and use money wisely if we're wasting money in this way.
Thank you, Justin. Janet, did you want to come back on that?
Yeah, I did. Sorry. I guess that's a really helpful answer, Justin. Thank you. I guess my challenge then would be, if we know that's the case, if we know that's the working pattern, are we looking at this, and maybe it's a conversation, Penny, for you and I and Justin to sort of have at the People Committee, but around maybe more flexible approach to medical workforce, because you know, surely there are other more creative ways we could fill those gaps, as well as you rightly say, Justin, people having more robust conversations about working patterns and making sure that we spread those really important skills across the week, as well as the fact it's better for patients as well, I believe, if we're using our substantive doctors rather than relying on, you know, if you come in on one day, you're much more likely to see an agency doctor than you are on another.
Yeah, thank you, Janet. Karen, I think I saw your hand raised. Did you change your mind?
It was just on it was on exactly the same type of theme. I mean, my only additional comment, because I think Janet said virtually everything I was going to, and Justin's given a very complete answer. It's just that in our targets, we talk about there being 8% or trying not to go above 8% in terms of bank and agency spend. And I just wondered why this magical 8%. Should that be less if we have more substantive tasks? You know, so are we actually really being challenging enough in terms of what we do? Because we do know, and we do want to have more, much more substantive stuff in, and not just for financial reasons. It's because we know it improves our quality and safety as well. So, you know, I was just really going to challenge the 8% and ask why it's there.
Penny, do you want to respond on that, or do you, Justin?
Yeah, I'll go first, Justin, if that's all right. So we do have targets from NHS England that we have to report against. I think you're right, though, Karen. Just because someone gives you a target of X%, it doesn't mean you can't strive for better. And Justin alluded early to a piece of work that we have from our variable pay event, actually, which looked at it. Is how we roster, that's a very broad, is how we roster optimum for the trust? And I think this, you know, the answer is probably not. We could do better, which is why we're looking at bringing a single rostering function in. And with that comes, you know, other things that we'll do. So I think you're absolutely right. A more stable workforce, a permanent workforce is better financially and for our patients and colleagues. And that's what we strive to. I think there are a number of different layers to that: job planning, job rostering. There's a whole host of other things that we're taking into consideration, and we're looking at road mapping now, kind of how we are going to address some issues with certain groups of staff. I think previously it may have felt like death by a thousand cuts. You know, we're going to do this, then we're going to do this, then we're going to do something else. What we're trying now to do is certainly a 12-month roadmap, but longer than that. And Justin and I are sitting down next week to plan out how are we going to address these issues, what comes first, what builds on what. So we've actually got a logical program of events so that we can also start to address unintended consequences. I think sometimes when you're driven by you just need to do it quickly, that drives action, but it prevents unintended consequences being seen until a risk becomes an issue. So we're trying to take a bit more of a considered approach. But I think you're right. Just because someone gives you a target, it doesn't mean you can't strive for better. Thank you.
Thank you. I can't see more hands at the moment. I had one question on the people, since we're on the people quadrant at the moment. Penny, one of the things that is highlighted within the report is the fact that whereas a lot of our staff engagement data is moving in the right direction and there's lots of positivity, there was a rather concerning stat in there about the relative likelihood of a white applicant being appointed compared to a black applicant, where we've actually gone, instead of parity, we were at 1.69, we're now up to 2.44. That's quite a significant jump up. And I'm sure the team are very focused on it, but I wondered if we had any understanding of what's led to that.
I'm not sure I could give a clear answer as to why. Obviously, there are actions that we are taking to try and minimise whether it's unconscious bias or things in the process that perhaps disadvantage other groups, inclusion ambassadors, is a really good example of that. It's a good opportunity to get a different perspective, and also to have different voices around the table. One of the things that we're looking at is how we recruit, and looking more broadly at our assessment processes, and whether under the banner of kind of inclusive resourcing. So whether inadvertently adverts go out with a particular type of language and wouldn't appeal to particular groups. In tandem with that, and I've mentioned before, I'm hoping to kick off a restructure in a couple of weeks' time, or certainly within a month, focusing on talent and looking at areas of the population where we have really talented individuals from ethnically diverse backgrounds or other backgrounds, and they're not moving up, and understanding the barriers to that. Our staff network groups are really important for that, and I've already started to have some really good feedback from the REACH network, which is race equity and cultural heritage, as to why it might be slightly different. For example, someone from an ethnically diverse background might need encouragement to go for the next role. They might not be that confident, it's just a cultural thing, whereas someone else might put themselves forward and sell themselves well. So we're looking at different barriers to different groups, and trying to come up with something that still allows a level of consistency, but actually adapts itself to remove barriers for certain groups. And I think that's certainly something we're continuing to work on.
Sorry, I've got to put myself on mute. No, thank you. And I'm sure we'll watch this space. It just was quite an alarming increase, which is why I was concerned. We spent a bit of time talking about people. Did anyone want to raise anything on one of the other quadrants? Quality, operations, finance. I know we'll be talking about finance probably a bit later on, but operations or quality, anything that anyone would want to add or comment on? No? Okay. Thank you thank you very much for the paper. Can I just say, I really like that new slide at the beginning talking about the oversight framework. I think that's great. So well done, whoever came up with that idea. I think it's really good. Thank you, Teresa. Again, a very comprehensive summary. So I think that worked really well. So that's great. So if we're happy to move on, I don't see any other hands. Thank you. We'll move on from here. Next paper. Right, we next go into the quality and safety report from the committee. So I'll hand over to David.
Thank you. I'm not going to add much. I think it's there in the report. Just to note at the end of the report that I am making changes with the committee. We've gone back to 11 committees a year. We're getting about a dozen PSSIs, and we need to address those properly and give them time. And we're also inviting all authors of all papers to attend so that they can see how their paper is responded, how we respond to their paper. But I'm going to leave it at that, if that's okay, Anita.
Thank you, David. Any questions or comments for David and the Quality and Safety Committee? No? Okay, let's move on then to finance, planning and performance. Richard isn't here today. Karen, I don't know if you wanted to highlight anything.
I think we've already said a little bit in terms of the financial challenges, but I think for me the biggest challenge there is the sheer volume of stuff, if I can use that technical term, that the finance team and the business information teams are having to cope with at the moment in terms of all of the performance planning that's got to be done over the 3 to 5 years. I think it's worth it, because I think being able to plan over 3 to 5 years will really help us. I know that there's been concern around our ability to engage as effectively as we would like, given the really short timescales. But I think for me, the thing I would think of in relation to that is that this is a live plan, and it's not going to be in tablets of stone, and we can go back and we can move, and we and we can change. So I think there is an element of optimism around that. But for us, for this year, I think the challenges are extremely clear. It's not best, and Teresa already alluded to it in the IPR, that we are going to be reliant upon non-recurring savings to an extent that we would not choose to this year. We do have a substantial SIP programme, and I know that work is now ongoing at trying to identify and put in place, if we can, before the end of the financial year, some SIPs that will lead us through next year as well to begin to recover that. I think, again, to echo what Teresa said, I think it is a little bit of a call to arms by everybody in terms of the transformational changes that may be needed in order to actually achieve these SIPs going forward. So this isn't about finance, this is about the entire organisation, and this is real change that we're looking to. And I think there's been quite a lot of evidence of what we can do if we really push on that. I could see that that Kevin Howell put his hand up as I was talking, and I was wondering whether others wanted to come in at that point.
No, it's not on that. Sorry, Karen, if you want to complete, it's something on just the format of the paper. It's something completely different.
That's absolutely fine then. So no, that was really all I wanted to say on the finance side. On the performance side, I think, again, the paper's pretty clear on that. We are aware of what the challenges are, and I think those are pretty clearly reflected, but quite open to people asking any questions. Thank you.
Yeah, thank you, Karen, and want to just reiterate what Teresa said, but also you said. I think we're in a situation where we really have to get everyone to understand that the financial situation is not a finance problem; it's an everybody problem, and I think we really need to make sure that mindset is one that is really clearly articulated. Kevin, did you want to come in on your paper point?
Yeah, please, Chair. I just noticed on the recommendations, the finance is to discuss and the quality and safety is to note. I'm just not sure whether or not it's an assurance document to the board or it's a note or a discussion point.
I believe it's a discussion point, but Stuart, did you want to come in?
Yes, so they are assurance reports. They don't need approval.
Right, so I think it's, but I think Kevin's point is well made, that the QSC one says note and the other two say discuss at the bottom. So we just need to just get some consistency in that, but that's fine. Thank you. Kevin. Lucy.
Thanks very much. Really just to say on the point about the planning process and your broader point, Anita, about it's everybody's business, our financial position and the way that we utilise resources, just to recognise that each year we do better in terms of the planning process in working together between performance, planning, business information, finance and operational and clinical colleagues, and that's how our structure is set up to work.
Yeah, absolutely, Lucy. Thank you for that and agree. Okay, if there's no other questions for FPPC, let's move on to people and culture. Janet, was there anything you wanted to draw to our attention? Thanks.
Thank you. And just on that subject, really, of sort of joint planning, we did have some discussion around the sort of strategic workforce planning process, really the sort of regular one that happens where it's more about the numbers rather than anything particularly transformational, and just that there's a sort of willingness to be more connected and a recognition that a disconnect is there. But really in the context of the sort of 3-year and 5-year plan, I suppose just a bit of a plea to make sure we do have the opportunity to think transformationally, that colleagues have the opportunity to think transformationally around that, both in terms of the moves to place and also in terms of recurrent SIPs, really. And the only other point to note was really there was some ongoing discussion about whistleblowing and the existence or not of a separate whistleblowing policy. And just, I think there were a number of members of the committee who felt we needed a bit of a kind of watching brief on whether the current arrangements we have will be sufficient going forward.
Thank you, Janet. Any questions or comments for People and Culture Committee? No? Okay, then thank you for your reports. Let's move on to system. We've got the Herts and West Essex performance report. I tend to feel that Adam's follow-up report on the HCP is probably more meaningful, but I don't know if somebody does want to say anything about the Herts and West Essex report. Adam?
Yeah, I would just say, yeah, we have got into the practice of just noting it here, but as we comment, it's actually out of date for the rest of our conversations. But I think with the Herts and West Essex ICB no longer meeting in isolation, what I would add is that I've been chosen to be the Hertfordshire representative on the new wider ICB, certainly through till next year when it formally is established. And we'll see what the reports that come out of there and if they change and would add value to the board. But as you say, now we're increasingly focusing on what happens at place. I think that will supersede this in terms of the information coming to the board.
Great, thank you. In which case we note the report. Let's move on to the HCP committee report. Adam.
Well, I will be very brief, as I think the report was well summarised, not in my hand, I would say, but thanks to Rennie, and I will just take it as read and happy to take any questions.
Thanks, Adam. Any questions or comments from anyone? Karen?
Well, I thought it was an excellent paper, Adam, and not just because you didn't write it, but it was an excellent paper. I find it really interesting.
In which case I did write it, Karen.
So I did have one question, and it's something that I've actually been seeing, hearing a little bit on the news about, and that's to do with hospices and the Garden House Hospice and the pressures there. I was just wondering whether we've done any modelling of the impact of hospice care at all on us, and I was just thinking of in terms of our 3-year plan as we look forward and we begin to think of the HCPs, you know, whether we've looked at the impact of what happens in these sort of organisations on us as a trust, and you know, what this actually might mean to us as we move forward.
Yes, I think in response, so I think that the challenges that Garden House Hospice particularly have highlighted and raised a kind of fundraising campaign, etc., have probably sharpened the focus on the hospice sector more generally, because we obviously have others in the patch, and I think their finances, whilst maybe not have highlighted in the same way, are a challenge for sustainability, particularly with public giving over recent years, probably since the COVID pandemic, actually really being significantly less. The services are commissioned by the ICB, and in response to some of those concerns, the ICB have gone through a process and worked with Garden House, where I think we've reached a position where some of the immediate sustainability issues have now been resolved, certainly through this year. We had started to do a bit of work to understand if some of those beds for end-of-life care were closed, what would that mean? It doesn't now look like we need to do that. And part of the challenge, actually, Garden House Hospice has been quite forward-thinking in providing a number of services that aren't traditional inpatient end-of-life care. So I think commissions have been working with them to understand what is actually being commissioned and what services maybe are they providing that they haven't been commissioned to do, and seeing where the priorities are. So we've been very willing to get involved in that work to both offer support in the short term and longer term. But I think the short term crisis, because I think we did feel it would be a crisis if that provision wasn't there, because those patients would end up in the acute hospitals, and also particularly when some of those people are in that end of life stage, if they are not choosing the hospital to be that place, it then took away that choice. So yeah, recognise the concerns. At the time, we last met and this summary was done, I think we were particularly worried that it might be a very short-term problem. It's looking like it's going into next year, and in the high-level commissioning intentions from the new ICB, they do specifically talk about hospices in terms of part of the funding model.
Thanks, Adam. Jill.
So I couldn't find my pointer then to unmute. Thank you. I too really found this incredibly valuable to have this transparency and this update. So thank you very much for that, Adam. I was just interested in whether you'd produce this for the boards of all the constituent members of the partnership committee, really, or whether this was just for us.
Yeah, so this report is very much produced for us alongside the other committees of the board papers for this organisation. Clearly, all of the organisations represented get the summary minutes of the meeting for sharing in their organisation should they choose to do so. But this paper specifically is as a committee of this board.
Okay.
But thank you for the question, Jill. And I would add, when we spoke earlier on about the ICB performance report, we are now producing an HCP performance report, which still remains quite acute hospital focused and Eastern North Herts hospital focused because of ease. And what the challenge we've given those working on this through the system is how do we bring more community and primary care data in, frankly, beyond some of the access to same day treatment, which are important in primary care, but how do we expand those? How do we understand the performance of some of the other services like PAH, where a large part of our population who live on the border there will go to PAH, and social care are now trying to work on how they supplement some of those measures. So I think it will be an iterative process, but I envisage that will come through probably as a supplementary report to our board, whether every meeting or whether every quarter or 6 months, so we get a sense of our new responsibilities for the population more broadly. So hopefully it will supplement this as well.
Yeah, I think just to add to that, because I'm currently a non-exec on that committee, I think exactly as Adam says, I mean, this is because the healthcare partnership is a subcommittee of this board, this is a committee paper for us rather than anything else. I don't see any reason why we couldn't share that or elements of it with our partners, but it's done for our benefit because governance wise it's our problem, if you like, in a good way. But I also would totally endorse what Adam was just saying. I mean, one of the things that the conversation in those HCP boards is noticeably becoming a bit more mature. And I think in some of the other sectors, they're perhaps not used to having metrics and timelines and being able and having to talk about not just about what we're doing, about a trajectory. Where do we think we want to get to? So I think that's a new way of thinking for some of our partners. They're not things that come a second nature to us because we're used to working in those terms. I think some of our partners don't start from the same place, but I think the conversations are starting. I think there's a willingness and an understanding that that's where they need to get to. So I would very much like to think that we could say, watch this space, and we'll get something that allows us to get a bigger picture across a holistic picture across the whole piece, as to which bits of our system are performing well or less well, and how that looks. It's a little bit early days right now, but yeah, I think we're on our way. Right. If there are no further questions for the HCP committee, thank you, Adam. Audit and risk, Karen, anything you want to draw to our attention?
I think it's a fairly self-explanatory report, this one. It highlights, if you like, the key focuses of external audit and internal audit over the course of the next few months. There's not a lot of output at this point in time to report, but as always with the audit committee, as we go through the rest of the financial year and the end of the financial year, we'll obviously bring much more through to the board.
Thanks, Karen. Any questions or comments for Audit and Risk Committee? Nope. Okay. So then final committee report, charity trusts. Nina's not here, but I believe Diana, you're going to draw something to our attention.
Yes, thank you, Chair. I'll just take the paper as read, but one of the kind of key points to point out there is that under the alerts, obviously we've still got the delays with the Sunshine Terrace, but we do know that the final costings will come in at the end of December. I think one of the key things that Nina wanted to point out is that we understand now that we do have to do some work on improving our processes just to help make sure that any sort of major projects that we take forward in the future, we can make sure that we've got tight processes in place to avoid those delays. Also, I think there are a couple of things that Nina wanted me to point out in terms of highlights of positive things that have happened. We had our charity team attend the Hertfordshire Residential Development Awards, where they managed to raise over £90,000 for the trust, which is fantastic. We've also, charity's also been involved in developing a video, which kind of highlighted some of the support that's available for patients, and that's been led by one of our divisional directors, nursing, Lizzie Franklin Jones. She's part of a team that's actually helped to develop a new parents room and a parents bedroom at the NICU unit. And then finally, we've just had confirmation as well that we will be having a charity Christmas discount day, which will be on the 22nd of December, where staff will be able to benefit from having a range of stores with discounted items, toys, clothes, and all sorts of things like that, which I think will be really helpful.
Brilliant. Thank you very much, Diana. Some really fabulous news in all of that. And the last one about the sort of Christmas fair thing, yeah, I hope will be something useful and to some of our staff who perhaps were concerned about the payroll date in December. So that's a really lovely initiative. Adam, you wanted to come in.
Yeah, 2 points from me, very unrelated. So the first is just on the theme of Christmas events. On the 13th of December, at St Mary's Church in Hitchin, there is our carol service for, or Carols at Christmas concert, I think the title is, to raise money for the charity as well. So anyone is welcome to attend that event, and I will see you there. But I guess more fundamental, I just wanted to bring Kevin in, if he doesn't mind, briefly on the Sunshine Terrace, because I know this has been something that has been frustrating because we had some real generous contributions to raise this, and it has gone a long time, as Diana said. But I just wanted Kevin to make sure the board has cited on some of the challenges, particularly post Grenfell, that have really created some delays in this. So just Kevin, would you be able to just do that?
Yes, of course. I'm personally managing this project because it has taken so long, and I intend to have it built in one way or another, I can assure you. The original design moved dramatically due to cost constraints, and then when we had got the design finished, we fell foul of the new legislation, which meant that anything joining onto a multi-storey building fell under the Grenfell rules and regulations, which meant that any planning application didn't go to the local authority, it went to the Health and Safety Executive, of which there are very few people who actually monitor and manage this sort of thing. In addition to that, the methodology in which we actually make requests for these sort of buildings to go in was in its infancy, and we found it really difficult to understand who had the authority to send these things on. So we've got through that. In addition to that, of course, there was a massive cost involvement because we're now having to do a complete fire review of the tower and podium because we're putting a small adaptation, believe it or not, on the bottom of it. Notwithstanding that, part of that is part of what work we're doing for the fire precaution works anyway, so that has had to wait for that. Where we are at the moment is the job has been broken into sections. There's the Sunshine Terrace, which we've now got the costing for, and we believe we've got it within the parameters of the budgets that the charity has got. Then there's the underside work, and we're infilling below for future proofing, which would have to come out of future capital requirements at a later stage, or investment portfolio through something like NH Pharma or another commercial aspect, so we get a shopping unit on the ground floor. All of that said, we now have appointed a CDM and principal designer who is authorised on behalf of Health and Safety Executive, and the plans are going in. So we're at the last sort of stage. We're not quite sure what the approval timetable is, because it's not written down in any of the legislation. Whilst if you put in for a planning application in your house, it's 13 weeks and then it's deemed accepted unless there is an appeal against it. No such thing exists, and there's no one actually to talk to at the Health and Safety Executive who can advise us on it. So we are going a bit blind on that. It has taken an extortionate amount of time, longer than, to be honest, two of the hospitals I built took less time than this, and this is a small extension where we can push people out to actually see the sky in the last few moments of their life, which is, I think, extremely important. For the charity meeting on the 8th of December, I believe it is, there will be an update and review of all of this, giving the actual times, and included with that is the support or where we are with regards to the funding for the baseline below it. So we will have the definitive numbers. I did get a chance to speak to Eloise and Nia at the awards ceremony the other night and explain this to her, but we just need to finalise it and the full report to go to the charity committee, as I say, on the 8th. But we're still about, I'd say, 12 to 13 weeks away from just planning approval going through. And there are so few of these going through at the moment. I don't know whether it will go through on a nod because it is so small, or whether or not there will be a lot of other questions, but we've done a huge amount of work behind it. I know the frustration is there. I asked for forbearance till it goes through again. I wouldn't want to lose this. It is a very worthwhile project, and investors have been involved in this. And the other night when I had the pleasure of being at the meeting and talking to some of the investors around here, they were very interested. I don't know whether or not it was the red wine or just the fact that they were interested in talking to me, but there was a lot of potential investment there, and I think that the charity team are actually tapping into that well, and this can support projects like this and maybe going on to things like the paediatrics. So that's where we are at the moment.
Thank you, Kevin. Yeah, a very complex project. I think we're all aware of that. Jill.
Thank you. Just a very simple question, actually, Diana. I wondered if you could just give a sense of what the Maintain Energy Therapy Service means. What is that? That obviously attracts quite a significant element of funding.
I think that one, Jill, I'm probably going to have to kind of come offline and talk to you about that one. I don't have all of the major details. I'm not sure if either David does, but
yes, or David.
Sorry, don't immediately know. I'm just having a look.
No, we can find out outside then. I was just interest. That's all. I hadn't heard of it before. The others are all fairly self-explanatory. I didn't know what that referred to. That's all. We can pick that up outside.
Thank you. Yes, I have a feeling I know a little bit about it, but I wouldn't want to commit myself to it because I may be completely wrong. But it's about psychological, I believe it's about psychological support for patients who are undergoing renal, I think it's mostly dialysis, and I think it's psychological support, but with a view to maintaining personal energy, I think. But
right.
But I don't. But I may be making that up completely. So I'm just don't hold me to it. But I think that's what it's about. Right.
As I said, Jill. Sorry. As I said, Jill, I'm happy to kind of get some further information and come back to you.
Yeah, we can liaise. Thank you.
Great. Thank you. Lovely. Okay. I think. Thank you, Diana, for your report. That then just comes to the annual cycle is in the pack, just for noting. I haven't been informed of any other business, so I'm going to assume there isn't any. The date of our next meeting, it's a face-to-face meeting at Mount Vernon on Wednesday, the 14th of January. Look forward to seeing you all in person on that date. And if there are no other questions or comments, I'm going to bring the public or the meeting of the board in public. I'll bring it to a close. And thank